So today I'm going to talk about antifungal stewardship, so changing tact from PKPD and some of the micro talks that we've had earlier on today. And so firstly, I like to start with a definition. And antifungal stewardship, in a nutshell, is the same as AMS in general, but a little bit different. I like to think of it as a little bit different. So if you find this is a definition that's been published, it's a multifaceted approach to optimising antifungal use through implementation of evidence-based guidelines, improving access to diagnostics and careful prescription review. So far, very AMS-ish. And the aims are exactly the same as our general antibiotic or antibacterial stewardship. So we want to reduce inappropriate use, optimise patient outcomes, and ensure cost-effective therapy if we can. And we want to try and obviously minimise the harms that can come from overuse of antifungals, so including toxicity, which is definitely relevant, and antifungal resistance, which again is I guess antibacterial resistance takes priority in the media at least, but it is definitely a growing issue, as we've seen in the last year with Candida auris. So the aims are very stewardshipy to start with, but there are key challenges with the patient group, with the infection type, and with the agents themselves that may mean that the approach to antifungal stewardship and the focus and how we apply the strategies may be a little bit different. So this is just a summary slide of the differences from antibacterial and antifungal stewardship. And so just to point out this has been adapted from a really neat antimicrobial stewardship book from the UK on the chapter on antifungal stewardship, but it helps to point out and distill the slight differences. So antifungal stewardship really focuses in on key specialty areas with immunocompromised hosts, whereas antibacterial stewardship is all comers. Everybody's using antibiotics. It's seen in primary and secondary care, whereas antifungal stewardship and antifungal use is primarily in the hospital setting and in our immunocompromised groups. So in terms of indications, AMS is definitely focused in on treatment, short, sharp courses, and short, sharp prophylaxis doses. Whereas antifungals, we tend to use prophylaxis a lot more, so that takes up a lot more of the bulk of antifungal use, and the risk periods for a lot of the patients is undefined. Whereas, so there are some specific risk periods for some patient groups that are well defined. For example, AML patients who are profoundly neutropenic, that's when their IFI risk is at its greatest. But in general, the prophylaxis duration is not really well defined for a lot of the other patients. And of course, treatment duration is anyone's guess. So courses tend to be longer, whereas with antibiotic courses, they tend to be short, sharp. So your focus doesn't need to be as prolonged. And with the antimicrobial or antifungal agents themselves, they tend to be a bit more complex in general. So more complex PK, where the prescribers are a little bit less familiar with prescribing antifungals comparatively speaking, because they don't do it on a day-to-day basis. It's hard. The agents themselves are higher in cost, and toxicities tend to be a little bit more profound and agent-specific. So that tends to be the key differences with antifungal use and therefore stewardship. So I don't think I need to go through this because I'm probably talking to the converted, but antifungal stewardship is necessary. Mainly because, well, one of the reasons is because there's just a high cost of invasive fungal infection management as well as the antifungal agents. So we've got a figure of about $80,000 it costs to treat an IFI case. These IFIs or invasive fungal infections have poorer outcomes, high mortality and morbidity comparatively speaking, and we are seeing an increase of antifungal use across the board. And of course, with increased use comes increased overuse. So we have a lot of patients on prophylaxis, on empiric treatment because of the inherent diagnostic dilemmas with IFI. And we know from audits and clinical experience that the critical stewardship de-escalation opportunities are often missed with antifungal therapy because the stakes are high, but also because there's just a bit more uncertainty in terms of when and how to do that. And of course, there are unintended consequences that are quite significant, including toxicity and potential for drug-drug interactions, but also that antifungal resistance that can occur with low-level ongoing use. And of course, these challenges with antifungal stewardship and the patient groups and the types of infections and the agents that we use come with certain drivers for stewardship, and they're pretty obvious. Obviously, these patients are complex, these infections are complex, and the agent's PK and dosing is always complex. But we've also got this high mortality, which drives a lot of the overuse or prescribing of empiric and prophylaxis, and obviously the costs are more of an issue with antifungals comparatively speaking compared to some of the antibiotics that we use these days. So these are the key drivers for stewardship in this area, and the focus of the stewardship strategies can be slightly different. So just a little bit on cost. Cost is easy to measure from a pharmacy perspective. We can, it just takes 5 seconds to see how much we've spent on a certain antifungal in a year. And often that helps. In a way, it's good that it can identify increases in use, but it's really important that with that identification of increase in costs and therefore increase in use, we understand why the costs fluctuate. So ultimately, you might be worried that you've had an increase in IFI cases and you want to know why that's occurred. Have they not been using prophylaxis? Have we got a new patient cohort that is at risk? For example, have you introduced a new allogeneic service? That's an obvious red flag. Or has there been some sort of building works that are going on that are causing the flow-on effect for cases? So understanding why that happens is important. And there could be changes in prescribing practice. It only takes one single bad case or bad outcome in a particular unit to potentially change their practice and consider different practices that will impact on your budget as well. But cost is just one of the major drivers, but just one driver. So these are the structural elements. I think if you're planning to introduce an antifungal stewardship program, these are the structural elements that you could address to some extent, or at least evaluate to some extent, in terms of how well you're doing. And as you can see, it's very similar to antimicrobial stewardship. So are there prescribing restrictions and rules in place, and do you want them to be in place? Do you want them to be applied to all agents or specific agents? Do you want them to get approval from the ID department before they start, or are you happy for them to start empirically because of the IFI risk and mortality risk? And then do you have a way of identifying those patients who have started early on so you can then, as an ID unit or an AMS team, review those orders? Do you want expert post-prescription review and feedback to occur similar to your AMS structure? Do you want rounds to occur on specific agents or all systemic antifungals? And who do you want to perform these reviews? And that's kind of a contentious area and crosses over both AMS and infectious diseases. And so who's best placed to, and who should make up the group that reviews and provides feedback to prescribers? You need to have your rules in place as well, as I said before, and part of those rules are antifungal guidelines. So ideally, you should have evidence-based, locally adapted guidelines, but do you want them to be according to the indication, so invasive aspergillosis, or do you want them to be specific to your patient cohort that prescribes a lot of these antifungals, so haematology, liver transplant, or do you want it specific to the antifungal agent, so when whoever it is makes a decision to start the antifungal, the prescriber knows how to best prescribe the antifungal. And ideally you should have all of these things in place. So fungal diagnostics is sort of key in this area to help with early identification of the species, and to help with some of the culture-based testing sensitivity issues that come with taking blood cultures, which aren't as sensitive for fungal infections as they are for bacterial infections. So bringing rapid fungal diagnostics in-house is really advantageous in terms of cutting down your empiric antifungal use, if you can, because a lot of those tests have a high negative predictive value, which is helpful to stop antifungals given the right specimens that have been taken. And so you need to also define how you're going to use them and how you're going to use therapeutic drug monitoring in the antifungal group. And finally, you want to know, once you've got all these structures in place, you want to monitor the effects of these strategies that you've put in place. How has expert post-prescription review and feedback benefited your patients or benefited your antifungal use? And what's happening overall in terms of invasive fungal infection in your cohort. So you are ahead of the curve in terms of initiating prophylaxis in a key group of evolving risk group. So a little bit on antifungal stewardship metrics. These are, your standard antimicrobial stewardship metrics that you want to measure to see how you're tracking with a program. So obviously antifungal consumption and costs, you want to quantitate what you're using, but ideally you want to know how well you're using antifungals. And that's the key. And you can't, I'm going to harp on this later, but you can't do one without the other. But patient outcomes are the holy grail, and we want to know whether our stewardship interventions are actually helping with patient outcomes, their mortality, their length of stay, and their impacts on subsequent breakthrough IFI if you're using prophylaxis strategies. So a bit about antifungal costs. I've already spoken about that and the inherent issues with just focusing in on costs. They're helpful in that they're quick, easy to track, but they'll miss a lot of the under-the-radar stuff that's cheap, like fluconazole. And some people would argue that monitoring fluconazole use and optimising that is key in terms of your Candida species antifungogram. So antifungal consumption data is often used in the antibiotic area. So defined daily doses, or DDDs, are often used for antifungals as well as antibacterials, but there are inherent issues with antifungal using a defined daily dose with antifungals, because often with these agents they're weight-based dosing, it's indication-based, and also we dose adjust according to therapeutic drug monitoring, so there is no defined daily dose for most of these agents. So that can lead to confusion if you're just monitoring that. Days of therapy, length of therapy are sort of where the money is in terms of monitoring your consumption. How long are you using certain agents for, and is that relatively okay? But again, you need patient level data for that, and you can't use it in isolation. So you really need a qualitative metric. So your choice of a qualitative metric is broad, and again, these are a general stewardship metrics that are used in antimicrobial stewardship. So you can measure activities and how much work your program's doing as a measure of quality. You can measure how many guidelines you've got in place, whether certain processes are being done, tests are being performed in terms of diagnostic tests and TDM, and whether certain management practices are being done for candidemia, for example, but they're all sort of surrogate markers for quality prescribing, and they won't necessarily give you an outcome data at the end in terms of your patient outcomes. So measuring appropriateness is quite contentious in the antifungal area, mainly because you have to have a long attention span to assess antifungal prescribing. So what's appropriate at the start of therapy may not be appropriate in the middle of therapy, and then they're on it for weeks and weeks and months, and how do you assess overall that course of an antifungal? And it's difficult. There are some examples in the literature of attempts to do this, but it's difficult to judge exactly when you should be assessing antifungal appropriateness and how you can translate that into an appropriate intervention to improve that. So point prevalence surveys often don't capture everything that you need. They'll just get a little bit of the antifungal use, and often it's the most appropriate antifungal use in terms of guideline concordant prophylaxis, for example. So this is still a contentious area, and doing clinical audits that are detailed, that capture all this information, are complex and time-consuming. So there are inherent issues with this. But ideally, we should aim for some sort of appropriateness measure that you can do routinely, systematically, perhaps in certain indications or certain treatment group or patient groups where you want to measure appropriateness for in one aspect of antifungal prescribing. And this is an example of a score system that was used at the end of a course to assess the entire treatment period. So this is the way forward, I guess. Patient outcomes are the holy grail, and we obviously want to incorporate that with our whole metrics in terms of quality of use, quantity of use, and what's actually happening in the patient group, as well as in our microbiological outcomes. So that needs to be considered as well. So ideally, you'd have a combination of process as well as outcome measures as per AMS. So they're your sort of structural aspects of antifungal stewardship. Let's turn our focus towards how do we actually optimise antifungal dosing in the challenging patient groups. Firstly, who are challenging patients who receive antifungals? And I would argue that pretty much all of patients who utilise antifungals or prescribed antifungals are challenging, and they're challenging because if they have a documented or suspected infection, they're going to be difficult. There's going to be higher mortality, higher stakes, and sicker patients. The types of patients who receive antifungals often also have altered antifungal pharmacokinetics. So they're sicker patients, they've got multi-organ failure, they're on multiple treatment modalities and multiple medications, which make them complex. So I'd argue that all patients on antifungals, systemic antifungals, are challenging. And considerations for optimising antifungal doses include asking a couple of questions in terms of the indication, and that will help you decide whether your spectrum of activity and your choice of antifungal is appropriate. So whether you're dealing with an empiric, don't know what the fungal infection, or if indeed there is a fungal infection present, versus your directed therapy where you've got a bit more information. And that'll help you narrow or broaden the spectrum. Where the site of infection is, that will often help with your choice of antifungals, or at least limit your choice. So, for example, Candida has a number of sanctuary sites that it will hide into, and some of the antifungals don't get into those sites. So you have to think about the pharmacokinetics and where these agents get into in terms of the site of infection. And your patient characteristics also will influence your antifungal choice, whether you can use that antifungal in the first place, and your availability of therapeutic drug monitoring to help with dosing, as well as concurrent drug interactions, which will limit what you can use, but also, if you can use it in combination, it might affect your dosage that you use. And this is just a summary of some helpful guidelines and apps that you can use to help with those clinical decisions on the go with antifungal prescribing. That's all I wanted to talk about today. Does anyone have any questions?